Precision Oncology, BiTES, and ADCs. Cancer therapy is undergoing a major transformation. For decades, traditional chemotherapy worked by attacking all rapidly dividing cells, cancerous or not, leading to significant toxicity and collateral damage. But modern oncology is moving towards precision medicine. Instead of broadly destroying cells, newer therapies are designed to identify the specific tumor targets and selectively eliminate the malignant cells with the far greater accuracy. Two of most revolutionary advances in this field are BiTES, bispecific T cells engagers, and ADCs, antibody drug conjugates. BiTES function like molecular bridges. They physically connect a patient's T cell to a cancer cell, forcing the immune system into direct contact with the tumor and triggering the targeted cytotoxicity. One of the most successful examples is Blinatumomab, which is demonstrated remarkable rates in the relapsed or refractory B-cell acute lymphoblastic leukemia. On the other hand, ADCs act like guided missile systems. They combine the specificity of monoclonal antibodies with higher potent cytotoxic drugs, delivering the chemotherapy directly inside cancer cells while minimizing the systemic exposure. Today, more than 14 FDA approved ADCs are already being used across multiple malignancies, including the breast cancer, lymphomas, and lung cancer. In this presentation, we will decode the science, mechanisms, clinical applications, toxicities, and exam relevant concepts behind breaking targeted therapies and understand why they represent the future of precision oncology. The problem traditional chemotherapy can't solve. To understand why precision oncology became necessary, we first need to understand the limitations of traditional chemotherapy. Consider this clinical scenario. A 29-year-old patient with B cell acute lymphoblastic leukemia or BALL presents in third relapse after failing two prior salvage chemotherapy regimens. The disease burden is massive, with bone marrow blast reaching 72%. Biologically, the leukemia cells are CD19 positive, making them potentially targetable. But clinically, the situation is extremely difficult. This is where the conventional chemotherapy often begins to fail. First, multi drug resistance. Cancer cells can overexpress the drug efflux pumps such as MDR1, actively removing the chemotherapy agents before they can induce cell death. Second, clonal evolution. Tumor cells continuously mutate under the treatment pressure, creating resistant subclones that survive the repopulate the disease. Third, T cell exhaustion. After prolonged disease and repeated chemotherapy exposure, the patient's immune system becomes functionally weakened and less capable of mounting an anti-tumor response. And finally, the bone marrow sanctuary effect. Certain tumor niche protect the malignant cells from adequate chemotherapy penetration, allowing the residual disease to persist despite the aggressive treatment. This is the central challenge of modern oncology. Traditional chemotherapy attacks rapidly dividing cells broadly, but cancer adapts faster than the drugs designed to kill it. Precision therapies like BiTEs and ADCs were developed specifically to overcome these resistance mechanisms by targeting the cancer cells with far greater specificity and immune precision. Selecting the right targeted agent. Now comes the most important clinical question when traditional chemotherapy fails. Which targeted therapy should we use? In relapsed or refractory B cell ALL, several advanced immunotherapeutic strategies are available, but each works very differently. The first option is Blinatumomab, a BiTE therapy. These molecules simultaneously binds CD3 on T cells and CD19 on leukemia cells, physically bringing the immune system into direct contact with the tumor. The rapid result is T cell activation and targeted killing of CD19 positive blasts. However, because the molecule has very short half-life, it requires continuous intravenous infusion over 28 days cycle. The second option is Inotuzumab Ozogamicin, an antibody drug conjugate ADC. Unlike BiTEs, ADCs do not rely primarily on T cell engagement. Instead, the antibody targets CD22 on leukemia cells and delivers a highly potent cytotoxic payload. In this case, calicimycin directly into the malignant cell. Once internalized, the payload damages the DNA and induces apoptosis with far greater specificity than standard chemotherapy. And finally, the CAR T cell therapy. This is perhaps the most personalized approach in the modern oncology. The patient's own T cells selected, genetically engineered ex vivo to recognize the tumor agents, antigens such as CD19 expanded in the laboratory and then reinfused back into the patient. These modified T cells can produce deep and durable remissions, but the process is complex, expensive, and requires lymphodepleting chemotherapy before infusion. So, clinically, the decision depends on multiple factors: tumor burden, expression, prior therapies, patient fitness, treatment availability, and urgency of the response. This is the essence of precision oncology. Not every targeted therapy is interchangeable. The right drug must match the right biology. Now let's apply precision oncology to our patient Rohan. Why does Blinatumomab fit his profile so well? First, his leukemia cells are CD19 positive. That's critical because Blinatumomab works by linking CD3 on T cells to CD19 on B cell blast, creating a direct immune attack. Second, despite prior chemotherapy failures, Rohan still has functional endogenous T cells. BiTE therapy can reactivate and redirect these T cells even when they appear exhausted or energetic. Third, he is Philadelphia chromosome negative. That means TKI resistance is not complicating the treatment landscape, making immune targeted therapy a cleaner strategy. And finally, disease burden matters. Blinatumomab performs best in low volume disease and MRD positive settings where immune mediated clearance is most effective. So, clinically, this is near ideal setup for BiTE therapy. BiTE therapy. Target present immune cells available and the biology aligned for the response. This is the essence of personalized oncology, choosing the right weapon for the right patient. Now let's understand the actual mechanism behind the BiTE therapy, how blinatumomab engineers a lethal response in the immune synapse. Step 1 is dual binding. The BiTE molecule simultaneously binds CD3 on T cell and CD19 on leukemic B cell, physically bringing them together. Unlike traditional antibodies, it has no Fc region, making it a very small molecule with a short half-life, which is why it requires continuous IV infusion. Step 2 is T cell activation. Once the T cells are bridged, the T cells become activated independent of MHC presentation. This is powerful because the cancer cell cannot easily escape through the antigen presentation defects. Activated T cells release cytokines like IL-2 and interferon gamma, amplifying the immune response. Step 3 is the targeted cytolysis. The activated T cell releases perforin and granzyme B directly into the leukemic cell, triggering the apoptosis. Importantly, there is a minimal bystander damage because the immune attack is highly localized. After killing one blast, the T cell disengages and moves on to attack another, a phenomena called serial killing. And finally, clinical response. This mechanism translates into the impressive MRD negativity rates, ranging nearly from 40 to 78% in clinical trials. That is why blinatumomab received accelerated FDA approval and became a landmark therapy in relapsed B-ALL. This is precision immunotherapy in action, redirecting the patient's own immune system into a highly specific anti-cancer weapon. Now let's move to antibody drug conjugates, often called the Trojan Horse of Cancer therapy. The concept is elegant. Use an antibody as a delivery vehicle to smuggle an entire ultra potent chemotherapy payload directly into the cancer cell. An ADC has three critical components. First, the antibody. This is the targeting system. It recognizes specific tumor antigens such as HER2, CD22, and TROP2, allowing the drug to selectively bind malignant cells while sparing the normal tissue. Second, the linker. Think of this as a molecular fuse connecting the antibody to the payload. The linker can be cleavable, activated by the acidic pH or tumor proteases, or non cleavable for greater stability in circulation. One key design parameter is drug antibody ratio or DAR. Too little payload reduces the efficacy, too much increases the toxicity. The ideal balance is usually around 4 to 8 drug molecules per antibody. And the third is the cytotoxic payload. This is where the ADCs become extraordinary. These drugs are often 100 to 1000 times more potent than the standard chemotherapy agents. Common payloads include the most drugs, molecules far too toxic to give systematically on their own. So the antibody acts like a guided missile. The linker controls releasing time and the payload delivers the lethal hit directly inside the cancer cell. That's why ADCs represent one of the biggest revolutions in the modern oncology, combining the precision targeting with extreme cytotoxic power. Now let's follow what actually happens after an ADC reaches the cancer cell. ADC is the antibody drug conjugate. Step 1 is the antigen binding. The monoclonal antibody component recognizes and binds a specific antigen on the tumor cell surface. This is precision targeting step that differentiates ADCs from the conventional chemotherapy. Step 2 is internalization. Once bound, the entire ADC antigen complex is pulled inside the cell through endocytosis, forming an endosome. In other words, the cancer cell, unknowingly imports into its own toxic payload. Step 3 is the linker cleavage. Inside the lysosome, the acidic environment and the proteolytic enzymes break the linker connecting the antibody to its drug payload. This releases the active cytotoxic agent directly within the malignant cell. And step 4 is the cytotoxic kill. The released payload travels into its intracellular target, often the nucleus or microtubules, where it causes catastrophic DNA damage or mitotic arrest, leading to apoptosis. But there's another important concept here, the bystander effect. Some payload molecules can diffuse out of the target cell and destroy the neighboring tumor as well. This becomes especially useful in the heterogeneous tumors where not every cancer cell expresses the same antigen density, so the ADCs function like a molecular Trojan horse bind, internalize, release, and destroy, all while minimizing the systemic toxicity compared to the traditional chemotherapy. That's the engineering brilliance behind the modern ADC therapy. Now let's compare two major targeted approaches head to head. BiTE therapy with the Blinatumomab versus the ADC therapy with the Inotuzumab Ozogamicin. Starting with the mechanism, Blinatumomab is a BiTE, a bispecific T cell engager. In contrast, Inotuzumab is an ADC that delivers the cytotoxic agent calicicamicin directly into the CD22 positive cells. Next is the administration. Because blinatumomab has a very short half-life, it requires continuous IV infusion through a pump over 28 days. Inotuzumab is a simpler, logistically given as an intermittent IV bolus dose on days 1, 8, and 15 of a 21-day cycle. Now, the key toxicities. For blinatumomab, the major concerns are cytokine release syndrome and neurotoxicity, particularly ICANS. For inotuzumab, the biggest issue is hepatotoxicity, especially veno-occlusive disease or sinusoidal obstruction syndrome, along with thrombocytopenia and occasional CRS. What about efficacy? In relapsed or refractory B-ALL, blinatumomab shows overall response rates ranging from roughly 40 to nearly 70% in major trials like BLAST and TOWER. Inotuzumab demonstrated even higher complete remission rates around 81% into INOVATE trial. But MRD negativity is where both therapies become extremely valuable. Blinatumomab achieves MRD negativity in nearly 78% of responders, while inotuzumab achieves around 73%. Finally, bridge to stem cell transplant. Both therapies are commonly used to get patients into remission before SCT. However, with inotuzumab, the risk of post-transplant hepatod becomes a major consideration. So, clinically, the choice depends on multiple factors: tumor burden, antigen expression, transplant plans, organ function, and toxicity profile. This is the essence of precision oncology, selecting the right biologic weapon for the right patient at the right moment. Expanding targets beyond leukemia. And this is where the real revolution begins. These therapies are no longer limited to leukemia. Antibody drug conjugates are now transforming the treatment landscape across multiple solid tumors and lymphomas. Take trastuzumab deruxtecan or TDXD. It targets HER2 positive cancers and delivers highly potent payload which can directly reduce the tumor cells. It shows remarkable survival benefits in HER positive breast and gastric cancers. Then that's there the transumab imastine, or also known as TDM1, which combines HER2 targeting the microtubule inhibitor DM1, essentially converting a monoclonal antibody into a precision chemotherapy delivery system. In lymphoma, brentuximab vedotin targets the CD30 positive malignant cells using the MMAE payload, dramatically improving the outcomes in Hodgkin lymphoma. And in urothelial carcinoma, enfortumab vedotin targets Nectin-4, again using MMAE to selectively destroy the tumor cells. What's important to understand in this? The platform remains the same: antibody, linker, payload. But by changing the target antigen, we can adapt ADCs to entirely different cancers. This is precision oncology evolving into a modular therapeutic platform. Navigating the immune storm, BiTE toxicities. Now, the BiTE therapies like Blinatumomab are highly effective. They come with a unique set of immune related toxicities that every clinician must recognize early. The first and the most common complication is cytokine release syndrome or CRS. This occurs because of activated T cells suddenly release the massive amounts of inflammatory cytokines. Patients may develop fever, hypertension, tachycardia, hypoxia, and systemic inflammation. Fortunately, most cases are mild, grade 1 or 2, but severe CRS can become life threatening if not managed promptly. Treatment improves the supportive care, temporary interruption of the infusion, and IL-6 blockade with tolizumab, often combined with dexamethasone. The second major toxicity is ICANS, ICANS, immune effector cell associated neurotoxicity syndrome. May present with confusion, aphasia, tremors, seizures, or altered consciousness. Unlike CRS, neurotoxicity responds better to corticosteroids than tocilizumab. Early recognition or assessment of the neurological is critical because the symptoms can progress rapidly. The third compilation or the complication seen is tumor lysis syndrome (TLS), especially in patients with high tumor burden. Rapid destruction of leukemic cells release potassium, phosphate, and uric acid into the circulation, potentially causing arrhythmias and acute kidney injury. Prevention is essential. Aggressive IV hydration, allopurinol, and rasburicase, and close electrolyte monitoring are standard protocols. The key clinical message in this is BiTE therapy is incredibly powerful, but its immune activation must be carefully balanced with vigilant toxicity monitoring. Early recognition saves life. Managing the payload collateral damage, ADC toxicities. Unlike BiTEs, antibody drug conjugates, ADCs cause toxicity primarily through their cytotoxic payloads. Because these drugs deliver extremely potent chemotherapy directly into the cells, collateral damage to normal tissues still occur. The first major toxicity involves the liver, specifically the VOD, veno-occlusive disease or sinusoidal obstruction syndrome, commonly associated with the Inotuzumab Ozogamicin. This occurs when hepatic sinusoidal endothelial cells are injured, leading to painful hepatomegaly, jaundice, ascites, and potentially fatal liver disease or fatal liver failure. Incidence may reach 15 to 17%, specifically in patients proceeding to the stem cell transplantation. Management includes supportive care and defibrotide, which is currently the only approved curative therapy. A crucial clinical warning is to avoid stem cell transplantation too soon after inotuzumab exposure, as this dramatically increases the VOD risk. The second important toxicity is interstitial lung disease or ILD, particularly seen with the trastuzumab deruxtecan, also known as the TXT. Patients may initially present with a subtle cough or dyspnea, but progression can be rapid and fatal if missed. Early diagnosis is absolutely critical. The moment ILD is suspected, the ADCs should be stopped immediately and high dose corticosteroids is initiated. The third category is peripheral neuropathy, commonly associated with the MMAE containing ADCs. These agents disrupt the microtubules not only in the cancer cells but also in the peripheral nerves, leading to numbness, tingling, burning pain, and sensory deficits. Neuropathy is cumulative and dose dependent, meaning symptoms worsen with prolonged exposure. Management mainly involves dose reduction, treatment delays, and symptomatic relief with the agents like gabapentin. But unfortunately, complete reversal is not always possible. So, while ADCs offer extraordinary precision, clinicians must remember that the payload still carries systemic risk. The challenge is maximizing tumor kill while minimizing the collateral toxicity. Board exam mastery, day 10 confusion. Let's apply everything we have learned to a classic board style clinical scenario. We have a 34-year-old man with relapsed Ph negative B cell ALL who is CD19 positive and has already failed two salvage regimens. He develops grade 3 confusion and asphyxia on day 10 after starting a novel targeted therapy. He develops the grade 3 confusion. Now, the key clues here are CD19 positive disease, relapsed, BALL, and delayed neurotoxicity, presenting with the confusion and aphasia. This strongly points towards Blinatumomab, the CD19 by CD3 BiTE therapy, and the complication begins as it is described in ICANS, immune effector cell associated neurotoxicity syndrome. ICANS is one of the hallmark toxicities of T cell engaging therapies. Symptoms can include confusion, expressive aphasia, tremors, seizures, and reduced consciousness. Management involves the immediately holding the infusion, initiating corticosteroids such as dexamethasone, and obtaining urgent neurological evaluation. Why are the other options incorrect? Rituximab commonly causes infusion reactions, but not delayed ICANS like neurotoxicity. Inotuzumab is associated with the hepatic VOD or SOS, not acute aphasia. And trastuzumab classically causes cardiotoxicity, particularly the reduced ejection fraction. So the correct answer is blinatumomab causing ICANS neurotoxicity. This is a high yield exam favorite because it integrates mechanism, indication, and toxicity into one clinical vignette. High yield oncology pearls. Before we conclude, let's rapidly review the high yield take home points from today's discussion. First, the definition of BiTE, BITE. A bispecific T cell engager simultaneously binds CD3 on T cells and tumor antigen on malignant cells, physically bringing the immune cell into direct contact with the cancer cell to trigger the targeted killing. The prototype example is Blinatumomab, which targets CD19 and CD3 because it lacks FC regions. It has extremely short half-life of about 2 hours, requiring the continuous IV infusion through a pump. Importantly, the TOVER Tower trial demonstrated significant overall survival benefit in relapsed or refractory B-ALL. Next, remember the structure of an ADC. Every antibody drug conjugate contains three essential components: a monoclonal antibody, a chemical linker, and highly potent cytotoxic payload. One critical pharmacological concept is the drug to antibody ratio DAR. A target DAR of approximately 4 to 8 provides the best balance between potency and stability. Now, for the major red flag toxicities, the DXT is strongly associated with the interstitial lung disease, which can become fatal if not recognized early. Inotuzumab Ozogamicin carries a major high risk of hepatic VOD or sinusoidal obstruction syndrome, especially in patients proceeding to stem cell transplant shortly after therapy. And finally, one of the most exam relevant distinctions: CRS versus ICANS. CRS primarily presents with systemic inflammatory symptoms such as fever, hypertension, and hypoxia, and is treated mainly with the tocilizumab. ICANS, on the other hand, present with the neurological symptoms like confusion, aphasia, seizures, and encephalopathy, and responds better to the corticosteroids such as dexamethasone. If you remember these core concepts, mechanisms, and toxicities, you will be able to confidently approach both oncology board questions and real world clinical scenarios involving the modern targeted immunotherapy. The future is molecular precision. As oncology moves beyond traditional chemotherapy, we are entering an era of true molecular precision. BiTEs harness the patient's own immune system by redirecting the T cells directly towards the malignant cells. ADCs, on the other hand, function like precision guided missiles, delivering the ultra potent cytotoxic payloads. That's exactly where they are needed. Different mechanisms, different toxicities, but one shared goal: maximizing the tumor destruction while minimizing the damage to the normal tissue. Together, these therapies are redefining how we think about the cancer treatment, transforming oncology from generalized chemotherapy into highly personalized mechanism driven medicine. And this is only the beginning. Future generations of the targeted therapies are already being designed with smarter linkers, dual payloads, improved tumor selectivity and reduced toxicity, and even combination immune engineering strategies. For students, residents, and clinicians alike, understanding these therapies is no longer optional, it is becoming essential for modern clinical practice. If you found this deep dive helpful, make sure to like, share, and subscribe for more high yield oncology and medicine content. The future of oncology is not just stronger treatment, it is the smarter treatment. Thank you for learning with me today. We explored how modern oncology is shifting from traditional towards highly targeted molecular therapies, from BiTEs that redirect T cells to destroy cancer cells to ADCs that act like precision guided Trojan horses delivering the potent cytotoxic payloads. And these innovations are transforming the cancer treatment. We also reviewed their mechanisms, clinical applications, major toxicities like CRS and ICANS, VOD and ILD, and the key examples that every future clinician should remember. The future of oncology is precision, personalization, and smarter therapeutics, and understanding these concepts today prepares us for the medicine of tomorrow. Thank you for watching. If you found this helpful, like, share, and subscribe for more high yield medical and oncology content. See you in the next session.